when I shifted to Jaipur. And this program is being coordinated by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery. We conduct online session for the surgical trainees every Saturday, 9 to 10 morning Indian time. And for the last 8 months, we've been doing this monthly masterclass, where on the last Thursday and Friday of every month, 7 to 9 p.m., we cover one topic. So we've conducted masterclasses on living donor liver transplant, on safe cholecystectomy, on acute pancreatitis, chronic pancreatitis, intensive care, and other topics. So the theme this time is ulcerative colitis. Yesterday, we covered some aspects of ulcerative colitis, and today we will touch upon some of the other aspects. So the first speaker for today is a very renowned colorectal surgeon from Singapore, Dr. Francis Seow-Choen. He's been a good friend for, I think, a couple of decades for me. I visited him several years ago, and he has been a regular and frequent visitor to India. He just now informed me that he was in Cochin just a few days ago for a meeting. So he is going to continue on what Dr. Das covered yesterday about the surgical procedures for ulcerative colitis. And he is going to tell us how to select what procedure. Some part of it was covered by Dr. Das also when he defined the various surgical procedures. So we will continue on that. And I was actually to take a flight to Delhi on my way to Nepal for a meeting, but my flight has got delayed. So that's why I could join, but I may leave in between anytime. And I've requested Dr. Das, and he has kindly agreed to continue to moderate the session. Das, please carry on.
Thank you, sir. Thank you, Dr. Francis. Could you recognize me? In 2013, you invited me for a talk you were organizing on Colorectal International Congress.
Yes.
So nice to see you after such a long time.
Yeah, thank you.
Sir, I know you are very reputed international colorectal surgeon, apart from other GI surgical procedures. So it will be nice to hear from you. But yesterday, what we heard or we discussed in our panel, let me just summarize that one. First, from Dr. Jayanti, we heard about an algorithmic approach to the medical management of ulcerative colitis. And she stressed on the coordination between the surgeon and the gastroenterologist on the ward go since we get the patient, because most of the time we found that the treatment was individualistic and it was tailored more or less to the requirement of the patient. She spoke about the newer regimens, the side effects, the vaccinations, and we agreed upon the fact that left-sided colitis should be treated like total colitis or pancolitis. We stressed about the preventive care and the patient education being so important in the management of ulcerative colitis. We discussed about the advances in therapeutics like stem cells, fecal microbiota transplantation, and artificial intelligence. And finally, she concluded by saying that still, we are in search for a right treatment for the right patient at the right time for ulcerative colitis. After that, Dr. Sujay from AIIMS New Delhi, he discussed about various indications and contraindications for surgical treatment for ulcerative colitis. So the summary was that the commonest indication for surgery in emergency setting is acute severe ulcerative colitis with failed medical therapy. Our study in AIIMS showed that the timing was preferably 7 days from the date of commencement of medical therapy in these patients. By that, we can reduce the mortality from 18% to 1%. The treatment of choice in emergency was subtotal colectomy with end ileostomy. And he again reiterated the fact that there should be a strong coordinated protocol between the gastroenterologist and gastrosurgeons for optimum management of these patients from the very beginning that the patient enters into the hospital. Finally, myself, Dr. Das from GI Surgery AIIMS discussed about various definitions of procedures that are used. Mainly 4 types of procedures are used in surgical management of ulcerative colitis. And we talked about some procedures which are not so commonly used, rather than rarely used, but still they have some indications in the therapy. So I would now request Professor Francis to take ahead the proceedings from what we left yesterday. He will speak about how to select the appropriate patients or appropriate techniques for restorative proctocolectomy, which is the mainstay of treatment for elective treatment of the ulcerative colitis, surgical part.
Well, first of all, thank you very much, Dr. Kapoor and Dr. Nash, for inviting me and for allowing me to speak. Now, today, I'm actually going to cover a little bit. There may be some, overlap between today's talk and yesterday's talk, because I wasn't around yesterday. But let me just get my slides in order here. Here we are. Now, can you see the slides here?
Yes, we can see.
Yeah, good. Yeah. So basically, I just want to cover in general detail, and I think so that we can cover quickly, and perhaps in the question answer time, we have more time to really go into more detail. But basically, I just want to talk about how to select the appropriate surgery, not just talking about restorative proctocolectomy in cases with ulcerative colitis. Now, we all know that the primary treatment of ulcerative colitis must be medical, and there are many medical therapies that I think you have discussed yesterday. But in spite of those, advances, a quarter, up to 40% of patients will sometime in their life require surgery. Now, when we talk about surgery, ulcerative colitis, there are 2 main situations. One is elective, and the other one is in the emergency situation. Now, when we talk about elective situation, when are those? First of all, there's chronic disease, especially those chronic relapsing disease. They keep relapsing, although we give them treatment of various sorts, perhaps stronger and stronger medication, and so forth, they still recur. Then, secondly, there is always that risk of cancer, especially in long-standing pancolonic ulcerative colitis. And of course, we know that especially in young patients, we have those complications of medical therapy and also failure of medical therapy. And those patients are what we call patients that need elective surgery. We also have a group of patients, a big group, in fact, we often see, who come in with emergency problems like toxic megacolon, perforation of the intestines, or massive bleeding, and those with acute severe relapse, where we need to treat them. Now, surgery in chronic ulcerative colitis, as we said earlier, besides those things that we talk about in the colon, we can also get uncontrollable pyoderma gangrenosum or exfoliative dermatitis, recurrent monoarthropathy or severe uveitis. And some of these may need some form of surgical treatment. Now, as far as when we look at ulcerative colitis, many of us don't realize this. I think especially in Asia or in East Asia, extra gastrointestinal manifestations, ulcerative colitis, is not so common. But I found in my time in Europe that they are much more common. So I'm not very sure about the Indian situation, but in East Asian, these extra GI manifestations are not very common. But having said that, the activity of these extra gastrointestinal manifestations cease after total colectomy in up to 50% of patients. And it's higher in UC compared to patients with Crohn's disease. But having said that, in certain extra gastrointestinal manifestations, surgery of the colon does not seem to have any effect. And this patients with ankylosing spondylitis and those with hepatobiliary complications don't seem to be helped by colectomy. So let's go on. Now, in patients with acute fulminating colitis, this is where a lot of our emergency surgery for colitis takes place. And the initial presentation seems usually to be the most severe. Subsequent acute relapses don't seem to be so severe. I think usually it's because these patients are treated already with various forms of drugs, although they may not be so effective, and that's why they are not as severe as the first episode where they are not treated at all. And this severe colitis leads very quickly in some patients to toxic megacolon or perforation. And of course, the prognosis depends on the extent of the severity of the colitis, the depth of penetration, and the severity of the attack. Now, if perforation does occur, then 3/4 of them will die. Whereas toxic megacolon itself or severe colitis itself, there's a low death rate. So when we see a patient with toxic megacolon, we need to act quickly. And in this situation, as Dr. Das has mentioned earlier, frequent consultation with the gastroenterologist is very important. And in fact, a lot of these patients present to the gastroenterologist, and we often have combined meeting with them, emphasizing to the gastroenterologist that they must refer patients early. A lot of them, tend to try medical treatment for far too long, until patients are very sick. Severe electrolyte abnormalities, patients are perforated before they refer, and that really is a wrong time. Patients should be referred and managed in conjunction with both gastroenterologists and us as surgeons as early as possible. And I think earlier, Dr. Das said, the speaker last night said 7 days optimum treatment. I think, in fact, a surgical consult should be done as soon as possible, and within 72 hours, a decision made for surgery if there's no improvement in the parameters, if the fever is swinging and colitis becomes severe and there's a severe wall edema of the intestines, one has really to consider if surgery should be done. And surgery, if it's indicated, should be done sooner rather than later. And as you know, toxic megacolon, just to put a word in there, if the diameter of transverse colon is more than 5.5 centimeters, we call that toxic megacolon. So 30% may respond to conservative treatment, but early surgical consult and emergency colectomy, really, by 72 hours, if there's no improvement in the parameters, rather than dragging on and trying various other medication. So let's talk about this sort of surgery, and we'll just go through this very quickly. These are some of the methods perhaps haven't been discussed, but or have been discussed. Blowhole colectomy is a very old operation. Ileorectal anastomosis is another one. Total colectomy and ileostomy, or proctocolectomy and ileostomy, where both the rectum and the colon is removed and ileostomy is formed. And then the restorative proctocolectomy, or the ileoanal pouch. Now, this is an operation that was done in the early days in the US. It has no place, as far as I'm concerned, in modern medicine. There's a very high incidence of sepsis, and in the end, all of them will require completion colectomy. Now, to do an ileorectal anastomosis in a patient who is very sick with toxic megacolon or with impending perforation is really not sensible. Or patients with high dose of steroids, or patients who are severely malnourished, because you're asking for perforation to occur, or leaking of the anastomosis, and that will make the patients even sicker. Yeah, so when we talk about what is the right procedure for such acute patients, we consider whether we should do a total colectomy, an ileostomy, or proctocolectomy and ileostomy. Now, we know that in these sick patients, mortality is very high. The proctocolectomy has a higher risk in these patients because the dissection and the time needed, and perhaps the difficulty to do this patient's rectum, versus just doing a total colectomy, which has a lower mortality rate. So most of us in a very, very sick patient, unless the patient is not as sick, we would really choose to just do a total colectomy and ileostomy. If there's bleeding from the rectum, we can always pack the rectum with a large piece of gauze or gauze wrapped in plastic for easier removal. And that works very well actually for emergency bleeding if we just want to do a total colectomy. Now, this really is, as I said earlier, is the safest option. Total colectomy, leaving the rectum and then ileostomy. Now, this is sometimes called the St. Mark's operation. It's popularized in St. Mark's Hospital. The rectal stump that is left behind can be oversewn, or in this case, as in the picture here, brought out as a mucus fistula. With this sort of operation, when a patient is well, other operations can then be considered. For example, you can do a subsequent ileorectal anastomosis if the rectum is not severely involved, or the patient does not want to run the risk of a pelvic operation or is worried about nerve injury, or we can go ahead to do a restorative proctocolectomy. So let's talk a little bit then here about the elective situation. Now, what sort of elective surgery? As we said earlier, in patients with chronic ulcerative colitis, especially pancolonic ulcerative colitis, there's a chance of cancer. And we know that the risk of cancer occurring in a patient with pan-procto ulcerative colitis is about 5% at 5 to 10% at 20 years, and every year after that increases about 1%. So constant surveillance is important, and the development of dysplasia during our follow-up of ulcerative colitis is an indication for surgery. And cancer is highest in acute onset colitis, patients with pancolitis, with colonic dysplasia, long-standing colitis, and young age at onset. So this is something that we have to consider carefully. And patients who had a ileorectal anastomosis, or patients who've had restorative proctocolectomy without mucosectomy, or just with staple restorative proctocolectomy, run also a risk of cancer in the retained rectal mucosa. So in elective cases, if we choose to do a total colectomy with an ileorectal anastomosis, this operation is not, you're not removing the risk completely, because the retained rectum can still give rise to cancer. And in order to do a total colectomy with ileorectal anastomosis, the patient must have minimal rectal disease or is willing to continue medical treatment of various sorts to the remnant rectum. So if we intend to take out the rectum, then what options we have? We can actually do what we call a pan-proctocolectomy. This is the operation where we retain the anal canal, but remove the rectum as well as the colon. Now, this operation is not widely used nowadays because although it sounds good, you don't have to have an anal wound. But in the old days, 20, 30 years ago, when we did some of these operations, we found that the anal remnant often breaks down, and then it leads to a cavity within the pelvis, which is sometimes hard to manage. But in both ileoanal pouch anastomosis or the proctocolectomy, all the disease is removed. There's much less cancer risk. And as I said, if we just do the pan-proctocolectomy, there is sometimes problem with the unhealed perineal wound, or what we call a pelvic abscess cavity. Now, if we do the restorative proctocolectomy, what sort of options do we have? You see here on the right of the pictures, we have on the left-hand side what we call an S pouch. You can see the shape of the S here. And then on the right-hand side, we see what we call a W pouch. The W pouch basically is two folds of an S pouch. So at that time, we believe that larger volume gives you a better function. And these two pouches, S and W pouch were popular in the UK, and they were pushed widely by surgeons in St. Mark's. Now, the one in the center, the J pouch, was popularized here in Asia, in fact, in Japan. I'll go through that in a while. So this design using about 40 to 45 cm of ileum. The other question is whether to do a anal mucosectomy or not, or no mucosectomy. So the J pouch, the S pouch or W pouch were popularized by John Nichols and Alan Parks. And I had the privilege of working with them actually in 1989 in St. Mark's. And here you see operating with John on the ileal pouch actually in those days. And because of the popularity of the St. Mark's surgeon, and also because of the good results they had, we had many visitors, and the operation was widely used at that time. But in Utsunomiya in Japan, popularized the J pouch. Now the J pouch has now become the most popular pouch. The reason is because it's simpler to use, and whereas the S and the W pouch had to be hand sewn, the J pouch could be easily fixed with one fire of stapler. Normally we use either 200 mm linear stapler, which will give you a 200 or 20 cm pouch, or 75 mm stapler, linear stapler, which will give you 150 mm long pouch. And the bottom of the J will be sutured to the anal canal. And that can be either a staple or hand sutured anastomosis. So basically, the technique of restorative proctocolectomy of the J pouch is like this. We can use either open or laparoscopy. I think most of us nowadays would use minimally invasive technique, that is to use a laparoscopy, or there are people also using robotic, of course. Most of us use laparoscopy because we are covering the whole abdomen. It's much easier to use laparoscopy rather than a fixed robot. The length of J pouch can be just fixed with 275 mm linear stapler, which will give you 150 mm long J pouch. Now, because we are using staplers, then most of us do not do anal mucosectomy. For myself, in my practice, I always use a defunctioning ileostomy in these patients, just so that we can avoid unforeseen leakages and unforeseen problems, and we can sleep better after we do the operation. My practice has always been to close this ileostomy at about 2 to 3 weeks. There is a technique we use to make the closure easier by putting seprafum below the level of the muscle within the anal canal, so that it's within the abdominal cavity around the end of the ileum, so it allows for easier mobilization. Now, with regards whether we should do a mucosectomy or no mucosectomy, as I said, because a lot of us are using staplers, so we do not do mucosectomy because it's much easier to do. But we have to consider why we do and why we don't do, besides the ease of using stapler to form the ileoanal pouch anastomosis. Now, if we retain the anal mucosa above the dentate line, this actually retains the transitional zone. And we know from anal physiological studies that the anal transitional zone gives us anal sensation. So if we remove that mucosa, actually it results in poorer anal function, a poorer sensate or sensation of whether it is gas, fluid, or solid. So excision of the anal transitional zone gives rise to worse anal function. But if we leave that mucosa, we ourselves in our patients have seen a couple of patients with cancer arising in the retained anal mucosa. So that's something that we need to monitor if we do not do the mucosectomy. And also that retained mucosa in some patients can get inflamed and result in in sort of retained mucosa colitis. So one has to be aware of all these issues if one does or one does not do mucosectomy. So just to show you, so this is on the left, you can see a patient with inflamed colitis, and on right, you see the ileal inner pouch that's been formed with the staplers in place. Yeah, so with construction of the pouch, we get much better function. With the J pouch, we get function that can approximate that of normal. I have many patients who have severe frequency, but after surgery, they approach normal. Although they don't have colon, with a properly constructed J pouch with a double staple pouch inner anastomosis, a lot of patients, they go to the toilet 1 to 3 times a day, and the stools are soft, not necessarily watery. Some of them have sort of form stool or very soft form stool. Now, the problems with pouches we see are patients with can develop colitis, or what we call pouchitis in the pouch. Some of them may need to be excised. We can treat them nowadays with various medication, including the usual medication we use for ulcerative colitis, or with antibiotics. Some of them may need pouch excision if the symptoms are very severe. And because of the operation that we do in the rectum, urinary dysfunction and impotence can result. Although when we do surgery of the rectum, for non-cancer cases, we do closed rectal dissection. That means we don't operate the rectum in the plane outside the rectal, the mesorectum, unlike in patients with rectal cancer. So that should mitigate or decrease the risk of pelvic nerve dysfunction. But some patients, even in females, they can develop dyspareunia with the pelvic operation as well. So when we look at ilio pouch inner anastomosis, we're not just talking about curing disease, but we want to give patients good outcome. And therefore, this is where how we form the pouch, what operation we do when we remove the rectum, whether we do closed rectal dissection, whether we do a wider resection if there's a rectal cancer, together with the ulcerative colitis is important. And also whether we decide to do mucosectomy or no mucosectomy. But when we do the appropriate surgery, it offers a cure for these patients with ulcerative colitis with minimal morbidity and no mortality if we're doing it correctly. And we must always look at our patients' quality of life as well as functional outcomes, because this will be improved. And if we find in our patients, the improvement in quality of life is not just dependent on the number of bowel movements per day, but with patients eating better, patients living better, their whole outlook in life is improved when various dysfunctional colon and rectum are removed, so that patients can really continue to do what they like, when they like, and have a good quality of life. Thank you very much for your attention.
Thank you. Thank you very much, Dr. Francis. Actually, your talk hasn't overlapped my discussion, what I did yesterday. I only enumerated the definitions of the surgeries. And I always felt in this session, it was a need to really cover the surgical aspects more extensively in all the aspects of ulcerative colitis. And you have very vividly addressed them. And it was very clear, and we could understand, we're pretty clear from your talk, the surgical strategies for managing ulcerative colitis. I don't really find any questions in the chart, and I myself also do not have any questions for you. I think this is mostly... Sir.
May I? So I think even if there was a little bit of repetition of the terms, it is very important for the students. And students, just to recapitulate, because there is confusion in many textbooks also between the two terms. One is what Dr. Francis used, pan-proctocolectomy, which is also called total proctocolectomy. So PPC or TPC, which means removal of the entire rectum, sacrifice of the sphincter, no normal passage, and a permanent terminal ileostomy.
Yes.
On the other hand, is restorative proctocolectomy, RPC, which means an ileal pouch anal anastomosis, which is the ideal procedure. Many textbooks still call RPC also as total proctocolectomy, which is not correct. So that is one. Two things I would like to ask Dr. Francis, which we discussed yesterday also, because this session is mainly for students, and students are often asked these questions in the exams. One is that when you are doing a total colectomy with leaving the rectal stump and a temporary ileostomy, what do you prefer to do in your practice? What do you prefer to do with the rectal stump? Do you close it? Do you close but keep it under the parietes? Or do you bring out as a formal opening a mucus fistula?
Yes, that's a very good question. As I said, in the St. Mark's Hospital in London, since the Alan Parks described the procedure and all, they have always been bringing the mucus, the rectum out as a mucus fistula at the bottom of the wound. Then they bring out the ileostomy as a stoma in the right iliac fossa. Now, this often leads to a little bit of wound infection at the lower end of the wound. And also, you really have to leave a much longer segment of rectum, which then, of course, gives you a bit more problems with continued proctitis in the remnant, rectum. Now, if you want to leave less rectum, then you have to oversew it or staple it off, and then you can just leave a short segment. Now, my own practice has been to actually try and dissect, depending on the patient's condition at the time of surgery. If his condition allows, he's not severely unstable, and anesthetists are quite happy, I will try and dissect as much of the rectum as possible, but not go into a very deep pelvis if the patient has a narrow pelvis and so forth. But just go as low as possible, as long as patient is stable, staple it off, and then bring out the stoma proximally. I think because in any case, sometime in the future, this patient will want to have an ileal pouch anal anastomosis. And in which case, if we are able to go as low as possible, then it makes our job easier also. And also anything if the rectum is short and if there's any issues like bleeding and so forth, we can always tackle it from the anal canal rather than having to, do some more extensive way of dealing with it. So my own approach to this would be to try and cut as much rectum as possible, oversew it, and then do this proximal stoma.
But when you say you would like, when you say you would like to go,
yeah,
when you say you would like to go as low as possible in the rectum, I'm sure you would not do any retrorectal dissection, because that would make the second surgery a little difficult.
Yes, no,
do you agree?
You always want to see when I do this operation in a patient with ulcerative colitis, I'm especially in males. Of course, females also have sexual sort of nerves and feeling, but males, especially with the risk of impotence, we always do what we call a closed rectal dissection. Now, in the old days, it was not easy because in the old days, we have to diatomize and cut, diatomize and cut. But nowadays, with energy devices, it's much easier because we're just cutting close to the rectal serosa and then going around, leaving a large chunk of the mesorectum behind, which will then mitigate against likely injury. However, if we're operating on chronic cases where there is operating because of cancer in the rectum, then it's a different story. Then we have to go outside the mesorectal plane. then that's a different story. But that would not be an emergency operation.
Yeah, actually, that was the second question which I was going to ask. So if we go close to the rectal wall and leave the mesorectal fat in the pelvis, in a narrow male pelvis, sometimes do you face difficulty in bringing the pouch through that narrow canal?
Yeah. The thing is this: if you dissect in the close, what we call the close rectal dissection, you find that the plane is not disturbed, and when we actually operate a second time, we can lift up that fat and we can actually do the normal sharp dissection in that plane, so that the pouch can then go in again. So that is not a big issue. We haven't found that to be a big issue.
Okay, thank you. Thank you. Yeah, Das, please carry on. Dr. Das?
Can you hear me?
Yes,
Thank you
yes.
very much, Dr. Francis. Actually, in a lighter vein, I want to say you that your photographs were exceptional. In fact, I was focusing on them. I would like to know what happened to that person after whom the crocodile was moving in the swimming pool.
Yeah. Yeah, we have to be careful of all these problems that we might face,
Okay, thank you very much. We would move to the next topic. That's a very difficult issue. Sometimes we face a lot of problem in taking decision if there is association of malignancy in ulcerative colitis, and the decision also changes when it is proximally present or distally present or different parts of the rectum. So it's necessary to discuss them in detail in a session. And for that, sir, Dr. Abhinav is there?
Abhinav, are you there with some other ID? I'll check with him. In the meantime, since Dr. Chetan is there, maybe we can have his presentation.
Oh, okay, it's fine. It would be better if we discuss the technical aspects what
Yes,
he is
yes.
going to speak, because we just finished discussing about the surgical management of ulcerative colitis.
Yes.
I would say just 2-3 lines about this. One is, we know the main cornerstone of elective ulcerative colitis surgery is the restorative proctocolectomy, and the heart of that is the pouch. Now, have you really mastered the techniques? If you see the literature over the period of time, the complications and the quality of life after pouch surgery has really not significantly changed over a period of time, maybe about 20 years or so. Now, why is that? Are we not able to master it? Or is it necessary to have a lot of experience, certain cases or certain procedures to master it? What are the problems? What are the tips and tricks of the trade? It's very essential to know. So who better than Dr. Chetan Kantharia, is a very famous surgical gastroenterologist, and he has excelled in many areas, and colorectal surgery is also one of his fields. And he is presently the head of the department of surgical gastroenterology in a very famous KEM hospital, Mumbai. So I would invite Dr. Chetan Kantharia to speak on the tips and tricks for restorative proctocolectomy.
Thank you, Dr. Dash, for such a very kind and generous introduction you gave to me. Respected seniors, dear students and colleagues. So I'm going to be discussing the tips and tricks for ILO pouch anal anastomosis. So whenever I'm asked to speak on tips and tricks, I always tell that there are no tricks. And the only tip is that you do in a very systematic and protocolized manner whatever procedure you want to perform. So we now begin straight away with the position of the patient. So the ileal pouch anal anastomosis in most of the cases is done in a lithotomy position. Only in certain cases, there are some people who prefer to give a prone jackknife position in patients where they have planned a mucosectomy of lower rectal mucosa because they feel that it gives a greater exposure than as compared to lithotomy position. But having said that, in our practice, we have done mucosectomy quite a few times, and we have done it very easily in lithotomy position itself. So the position generally is lithotomy position. Now, when we speak of the surgery, usually we do it in 3 stages, as Dr. Francis has described very nicely. So first stage would be the total colectomy with ileostomy. The second stage will be the restorative proctocolectomy with or without ileostomy. And the third stage will be, if the ileostomy has been done, then closure of the ileostomy. So whenever you do a first stage, the first step, irrespective of whether you are doing in a single stage or a 3 stage, the first step will be mobilization of the colon. So it's very important that you divide it along its peritoneal attachment. And usually you use energy device while dissecting the omentum from the transverse colon. And the terminal ileum is divided using a GIA stapler. Now, a word of caution is that many a times I have seen when you dissect the colonic mesentery, you become a little lax. So it is very important that it should be divided in a stepwise fashion by using either an energy device or a Kelly clamp applied doubly, cut it and tie it. Because there are abundance of blood vessels and lymph nodes in it, and it has to be given its due respect. Otherwise, what happens is you lose unnecessary blood loss, and by the time you reach below, when you are transecting the colon, you realize that quite a significant blood loss has occurred, and it adds to the morbidity. So you transect the lower end of the colon at the rectosigmoid junction, and it is usually divided with a stapler. We, in our practice, would take a running proline stitch and keep it long for us to identify it at a later stage when we go in for a second stage surgery. As Dr. Francis discussed that in their practice, they bring it out through the lower wound. We don't do so. We keep it here. And if you go after 6 to 8 weeks, it can be easily identified. And the long proline suture helps us to do that. Another thing which we follow is that we do not do much of pelvic dissection because we believe that it minimizes the formation of pelvic scar tissue, which if it occurs, it makes the subsequent second stage rectal surgery very difficult because of the adhesions it forms with what Dr. Kapoor was alluding to. So we try to avoid pelvic dissection as far as possible and transect it at the rectosigmoid junction. Another important thing which many of us overlook is it's very important to determine the ileostomy site preoperatively and bring out the ileostomy from an ideal site that is right and below of the umbilicus, but within the rectus abdominis. So when you go to the second stage, you mobilize the rectal stump which has been left behind from the pelvis down to the level of anus. Here, it is very important that you remain in the holy plane of Heald so as to prevent damage to the pelvic nerves. And you divide the rectum in such a way distally to leave a cuff of rectal tissue which should not be more than 1 centimeter. This is termed as a completion proctectomy because initially you had done only a total colectomy and now you are doing a completion proctectomy. And to divide the rectum distally, we routinely use a contour stapler, which becomes very handy and makes things very, very easy. This is followed by construction of pouch and ileopouch anal anastomosis. Now, when you are doing a restorative proctocolectomy, after you have resected or transected the rectal stump with the contour, you then take down the ileostomy from the skin and you bend the ileum itself in the shape of J so as to get a 15 centimeter length of pouch. You try to, before doing that, you will try to figure out whether the loop is reaching the base of the pelvis properly or not, whether it's under tension or not. Once you have confirmed that it is reaching very easily, it is not under tension, then the J is two bowel segments which make the J are connected to each other to create a larger lumen and thereby a pouch. And this is done by making an opening at the bend of the J and introducing a GIA stapler on either side of the limb of the J. The two bowel loops are connected with one or usually more than one firings of the GIA 75 mm stapler to create a reservoir that is ideally 15 to 20 centimeters long. Now, it is a very good practice that once you have done so, you ensure that there is no bleeding, and you can also insert through either a asepto syringe saline to see that there is no leak. Once you have confirmed that there is no leak, then you go ahead doing the pouch anal anastomosis, which is done with the end-to-end anastomosis circular stapler. So this circular stapler, we know that it comprises of the anvil, which is sutured into the apex of the pouch, which the opening you have made in the pouch. I'm going to show you a video at the end of it, which will make things more clearer. And then you take a purse string suture, or you can also staple it, and you bring out the apex of the anvil through the opening. The circular stapler is then introduced through the anorectal stump peranally, and it's advanced slowly by opening it so that it comes out posterior to the staple line. Then you bring in contact the anvil so that the socket of the circular device fixes into it and you get a click sound. It's very important that you hear a click, thereby confirming that it has apposed well. So once you have confirmed that the bowel ends are opposed, then the stapling device is fired. Then once the stapling device is fired, you turn it in anti-clockwise by taking 1.5 rotation, and then gently by wriggling action, you bring out the stapler. Once you bring out the stapler, it is very important that you see that completeness of the donut. Because if the donut is not complete, or if you find that it is deficient on a particular site, then that is an area of potential weakness, which you need to correct it on the table if you have identified. So this is a diagram showing the double stapling technique. It is called as double stapling technique because you are using two staplers, a contour stapler and a circular stapler. And hence this restorative proctocolectomy is also, which goes by the name of double stapling technique. Okay. So what important point you have to ensure before firing the stapler is that you have to see that the pouch is well aligned. Many a times it has happened that you fire the circular stapler and find that the pouch is twisted. So it's very important to ensure that doubly ensure that the pouch is not twisted. Another important thing, especially in females, is if you're doing many a times your assistant becomes little lax and he doesn't retract well, then a cuff of vagina comes in close contact with that and it gets opposed to the anastomosis. And post-operatively, these patients present with rectovaginal fistula. So, which they say that they pass feces or flatus through the vagina, and it's really cumbersome and troublesome. So, it's very important that you take care and ensure that the pouch is not twisted and the vagina is well retracted so as to prevent the vaginal cuff to getting anastomosed along with the pouch. Now, many a times, this is a very standard question which is asked in exams, that what if the pouch doesn't reach the pelvis? So you come across a situation where you feel, yeah, it is coming easily, but once the pouch has been constructed, you find that it is not reaching the pelvis easily. It's under tension. So what should be done? So first is you score the mesentery. It will lengthen to a certain extent. If that also doesn't help, then you take transverse anterior and posterior peritoneal incisions over the SMA pedicle, which will further lengthen it. If that also doesn't help, then you ligate the ileocolic, which will increase its length to a great extent. And if again this doesn't help, then selective division of secondary arcade mesenteric vessels to the apex of pouch. Very rarely you come across a situation where, in spite of doing all these things, you find that the pouch is not reaching. Then best is, rather than anastomosing it under tension at the risk of dehiscence, it is best to leave the pouch suspended in pelvis and anastomose at a later date in a hope that the edema will decrease and it will go and get anastomosed easily. So this is just the diagrammatic representation of the various maneuvers, the scoring around the SMA and the ligation of the ileocolic vessel, which helps in lengthening the loop of the pouch going down. Now, Dr. Francis raised the question that should mucosectomy should be done. Well, there are certain situations which demands that you remove the mucosa of last 3 centimeters of distal rectum. And it should be done in such a manner that you remove only the mucosa and keep behind the muscularis propria of the rectal cuff. So for this, you should, one uses either a saline or adrenaline solution. You raise the mucosa and you strip away from the internal anal sphincter and muscularis propria. And then when you do a mucosectomy, it is, you always have to do a hand-sewn anastomosis. You don't do a stapled anastomosis. You always do a hand-sewn anastomosis. So this is how you will inject, and as you see here, you strip the mucosa and then you anastomose it as shown here by taking multiple sutures along with the pouch. So what is the difference between, Dr. Francis very nicely explained it, that the double stapling technique is very easy to do. It preserves the anal transition zone, as a result of which there is improved function. You can distinguish between flatus, feces. However, the important thing is that mucosectomy decreases the risk of dysplasia, and this is one condition where you will, if there is a moderate or a high-grade dysplasia on your mapping biopsy, then you would do a mucosectomy. But it definitely does not decrease the cancer risk. So you will do it only if there is a moderate or a high-grade dysplasia. And when you do this, as I said, you have to do a hand-sewn anastomosis. So one never routinely does a mucosectomy unless and until there is a case for it, that is, there is a high risk of dysplasia. And there are enough literature evidence which suggests that mucosectomy should be avoided because the functionality gets hampered. Now, another question is, should we do a hand-sewn stapled anastomosis, or a stapled anastomosis? So again, there is this controversy and discussion goes back to late 90s, and there is enough evidence to show that stapled anastomosis is associated with less complications as compared to hand-sewn anastomosis. And it has also better outcomes and good quality of life compared to hand-sewn anastomosis. If you have to weigh the pros and cons, the stapled anastomosis has a shorter operative time. It improves continence by preserving the anal transition zone. And because of the preservation of the anal transition zone, there is a better nocturnal continence, and you can discriminate between flatus and feces. Here, hand-sewn anastomosis, because the anal transition is retained, there is risk of lurking dysplasia. And whether there is early functional outcome is better with hand-sewn anastomosis and mucosectomy is really doubtful as compared to stapled anastomosis. So the evidence is quite clear in favor of a stapled anastomosis, and there should be no doubt whatsoever that that hand-sewn has a role. So with this, I end my talk, and I will show you a small video of this particular procedure. So this is an open. Can you see the video?
We can't.
Okay.
No, not yet. Not
okay,
yet.
Okay. I'll do that.
I think you will have to stop sharing and then share again.
Okay.
So by the time you prepare your video, can I ask a question to Dr.
Yes.
Francis? I think he is online, most probably. I forgot to ask him that. Okay, we can see your video now.
Okay.
Please start from the beginning.
Yeah. So as I said that we begin with doing a colectomy by dissecting the colon of its peritoneal attachments. Here you see that we are in the the dissection is being carried out in the peritoneal fold. And if you are in the right plane, it doesn't bleed at all. So here we have reached the lower part, and you can appreciate that how inflamed the colon is. So now we have mobilized the colon. We are sequentially going to be dissecting, applying Kelly, and ligating it. So this is application of contour stapler to transect the lower rectal stump. So you examine for the transected staple line and see for its completeness. Now the pouch is being reconstructed. So this is the resected specimen, and you can appreciate how inflamed it is. And this is the complete dissection in the polyplane of heel. So now we are lengthening by dissecting along its peritoneal attachment. So this is how what I was saying, that you make a small opening at its bend. So that in each limb, the stapler is introduced. So while you're firing this, you have to see that it is well away from the mesentery. So we are just inflating it by injecting saline, instillation of saline, to see that whether there is any leak or not. So this is around 15 centimeters of this. Now we are going to be taking a purse string suture and introducing the anvil of the stapler. So this is a very crucial step. You have to take a proper purse string suture, and this is the anvil which has been introduced, and you have to take a purse string and tighten it very tightly so that it is well opposed. So this usually we take with 2,0 proline. Now the circular stapler is being introduced per anally. And as you can appreciate, it is going to, this is the staple line, it is coming posterior to the staple line. And we have taken adequate care to ensure that no other structure is coming here. So this is a red in color. And now we are going to fit into this, the anvil properly. As you can see it here. Then you oppose it by rotating the stapler so that it gets well opposed, and so you will come to know that it is because there is a window here which will show you that the two lines meet. Then you release the catch. And with a single action, you staple it. And again, you will get a click sound heard. And you keep it compressed for some time for purpose of hemostasis. You again apply the catch and anti-clockwise rotate around 1.5 times. And then with a wriggling action, Then we pour saline and instill air from the perennially to see whether there are any bubbles to rule out any leak. This is again a very important step to be done. And here you can appreciate the completeness of donut, and the donut is not deficient anywhere circularly. So this you see the complete donut. So this confirms that your anastomosis is perfect. So this is ileostomy, protective ileostomy, which you do. If you're very sure of that your anastomosis is good, you can give away what is we call as a modified 2 approach. Thank you very much.
Yes, Das, please. While Dr. Das is coming in, one important point for all students, the point which Dr. Chetan mentioned, that in the stapled anastomosis, in the stapled ileal pouch anal anastomosis, the anastomosis is not at the dentate line. It is about 1 centimeter or maybe even 2 centimeters above the dentate line, which is the anal transition zone. Whereas if you are doing a rectal mucosectomy and a hand-sewn ileal pouch anal anastomosis, which is always done perennially, then the anastomosis is at the dentate line. But more and more people are doing the stapled ileal pouch anal anastomosis. So that point, all the students have to appreciate the difference. Yeah, Dr. Das, please carry on.
Yeah. So that was a very lucid and extensive discussion and presentation of exactly how a pouch surgery should be made. But Dr. Chetan, you would agree with me if I say that there are many twists and turns and tricks of the trade when you actually do it, and it's not possible to describe all of them in a single presentation. It would come with experience and training.
Yes, yes.
Yeah. So what is your opinion? How many pouches one should assist or do to do it individually?
So basically, at our place, we generally make our senior residents do the initial part of the surgery. The pouch is usually constructed by one of the faculty members. The circular stapler is fired by the senior resident. So we make them assist at least around 10 before we give them to do this.
Coming to the technique proper a bit. Now, do you think laparoscopically we can really do the same thing exactly, or there are certain situations wherein open still has a place?
Nowadays, it is done more and more of laparoscopically. The place where you will do open is when there have been any complications. There are patients have been on steroids for a long period and it's very friable and you find that it's going to give away. So this is the time when you would definitely do laparoscopically, open. Otherwise, it's usually done laparoscopically.
Okay, and coming to the raw technique itself, how do we know that we have reached the proper level of resection just above the anorectal junction?
So what we usually do is that once you have dissected and you have determined the line of transaction at the point, you would ask one of your assistants to do a per-rectal examination and see where his finger reaches it. So it should be at least only half a finger, or this should be reaching to. And you can easily make out that this is the point where you are going to transact it. So you have to ensure you roughly come to know the length based upon the per-rectal examination.
Now, what is the size of the circular stapler that you use?
So in an adult male, we would usually use around 31.
So will there be any problem if we go deep down while dissecting? Once I have done that, I've almost reached the skin of the perineum, and then can you really stapulate at the sphincter? Is there any problem to do that?
Basically, then it would become like your proper pouch anal anastomosis, because you are going below the dentate line. So
Yes.
yeah, so but that in that case you will have to evert it outside and do an anastomosis outside and then reposit it back.
Actually, it is my practice to fix the pouch. One thing I used to do because rotating pouch is really a headache for the surgeon.
Yes.
What I do is after dissection and then division, just before firing the circular stapler, I see that it is opposed well, then check whether the rotation is okay or not. Then otherwise you have to then de-rotate it and then fix it again and then tighten it. That is number one. And I used to fix the pouch to the lateral wall of the pelvis to keep its orientation. Do you do that, or it's not necessary?
No, we don't do that. We don't do that. We just ensure that there is no twist. It is well aligned.
Okay. Have you experienced staple failure?
Many a times. Many a times, yes.
How do you manage that then?
So in that case, we do a hand-sewn anastomosis.
After dismantling?
After dismantling.
Even if there is a very mild trickle?
No. If there is a mild trickle, I will take a underrunning suture over it and let the ileostomy take care of it, because it will heal. If it's just a small defect.
And do you put a drain into the pouch?
No, we don't put a drain in the pouch.
And some Western literature says that you should do an endoscopy immediately after the procedure to see if there is bleeding. You can control that during that. What is your opinion?
So by instilling saline in the pouch, there are two things we ensure. One is that there is no leak, and the fluid, whether it's blood stained or not, that will tell us whether there is any bleeding or not.
And if you find bleeding, how do you control? It's quite, it's not so rare, isn't it?
It's not uncommon also. In that cases, you again take underrunning sutures, evert it and take underrunning sutures.
Yeah. You also very nicely showed a beautifully matured loop ileostomy. And do you want to say some points regarding how to go about forming a good ileostomy? What are the features of a good ileostomy?
So many a times what happens is that after doing this procedure, the ileostomy is left to the junior most colleague.
Yes.
So that should not be done. You let him do, but it should be supervised. Now again, you have to follow all the steps properly that you bring out. It should not be under tension. It should be adequate opening, not too small, not too loose, and very important that it should be everting. You should evert this ileostomy. Unlike the colostomy, which is flushed, you have to evert it, because that will prevent the excoriation of the surrounding skin. It's very important to do that.
And finally, I wanted to ask this question to Dr. Francis. If I may ask you, what is your strategy for indeterminate colitis? Oh, Dr. Francis is online. So could you answer this one?
Well, I think the problem with indeterminate colitis is that you are never sure. As you know, it's not just between Crohn's disease and ulcerative colitis. It's also between tuberculosis, and Crohn's disease. But you find that across the whole gamut of inflammatory bowel disease, you have about 10 to 15% of patients who has indeterminate. And when we say it's indeterminate, it means that initial diagnosis can't really, they don't give you enough histological pointers as to whether it's Crohn's ulcerative colitis. And some of these patients that usually what happens is that we think it's ulcerative colitis, and then in the end it behaves like a patient with Crohn's, and vice versa. We have had our fair share of this sort of patients. We just deal with them as whatever problems arise. Now, at a stage of them coming, let's say, to the point of needing surgery, we have to go by our best diagnosis. The pathologist tells us this is Crohn's disease, we treat it as Crohn's disease. If the pathologist tells us this is ulcerative colitis, we will treat it as ulcerative colitis. If subsequently the patient behaves like Crohn's, then we have to treat it accordingly. So we cannot at a time of surgery determine that it is definitely ulcerative colitis or it's definitely Crohn's, unless they tell us it is. But sometimes they still make a mistake. So once they say it's ulcerative colitis, we take it out, and the specimen that we take out, they say, oh, actually what you have done is you have done the ileal inner pouch for Crohn's disease. We just have to deal with it.
Yeah. Any comments or suggestions from your side regarding the tricks of the trade?
You're talking about surgery itself?
The ileal pouch anal anastomosis.
Yeah. I am, although I worked with John Nichols at St. Mark's, and he always used the S pouch. The S pouch is, when we are doing the surgery itself, the S pouch is a very good pouch if there's a short length. If your mesentery is foreshortened or short, and you can't bring, we always test before we actually do the pouch. We always bring, whether we're doing laparoscopy or open, we always try and bring the pouch down to the point of the top of the pubic symphysis. If your point of anastomosis can reach the top of pubic symphysis, you can usually go into the anal canal to do the anastomosis. Now, if we find that that is short, you can do an S pouch. I have not done the S pouch for a long time. The last time that we couldn't bring it down was maybe 20 years ago, and we did an S pouch, and it went down, because S pouch gives you about another 2 centimeters. But a more important one, which we always do, and some people don't do it, and that's why they can't reach, is actually to really mobilize around the superior mesenteric pedicle. Because often we mobilize, we are just, after we cut out the whole colon and the rectum, the small bowel, we don't mobilize. We just, take the ileum, mobilize ileum. If the ileum is stuck to the pelvis side while we mobilize that, we have to mobilize the entire ileal mesentery to the level of the origin of the superior mesenteric artery and the vein. Just mobilize it up to the level of the pancreas, and then make sure that we have mobilized all around the superior mesenteric vessel is free, because often that is the limiting factor. So I will do that. I will do that. And also, if you are doing the J pouch and you find that there is not enough length, you can fenestrate. Fenestration of the mesentery means you trans-illuminate the small bowel mesentery, and you cut in the fat in between the vessels. Don't cut the vessels. Those usually give you another 2 or 3 centimeters, plus adequate mobilization, and necessary, you use an S pouch instead of a J pouch. And those usually give you more than enough length.
That is so important a step in pouch anal anastomosis, particularly specifically if we're going to do a redo pouch. So Dr. Chetan, do you have any experience of redo pouch? Then I'll come to Dr. Francis. Please unmute. Please unmute.
So,
Yes.
fortunately, we have not done much of redo pouch, though we have done an excision of the pouch, but we have not done much of redo pouch. So not much experience.
Dr. Francis? Unmute. Please unmute.
All right. We
Yes.
have had a very few, we don't have many. Now, one of the things is that I find in my experience that pouchitis occurs somehow more often in Caucasian patients who have extra GI manifestations. I find that in Asians, not many of our patients have got extra GI manifestations. So I'm going to ask both of you as well. Have you seen patients with extra GI manifestation? I've seen very few in Asian patients. And because they don't have GI manifestations, I also see that they don't have a lot of patients. We don't have a lot of patients with pouchitis. not like what they report in the US or in the UK. So we don't have many patients with redo pouch.
Dr. Chetan, are you online?
Yes, yeah.
Dr. Chetan, the final question before I show you something very interesting that has happened just an hour back. I mean, at 6 p.m. I just finished, I came back. I will show you that. Before that, I wanted to ask, do you agree that the pouch problems that we are having in the post-operative period or long term are mainly related to the technique?
Absolutely. It's definitely related to the technique. If it's not done properly, if you find that there is bleeding, or if your staple line is not properly aligned, it definitely is one of the main cause for pouchitis to occur. So it has to be done. This is one surgery which has to be done absolutely without any haste.
Dr. Francis?
Well, yeah, well, part of it, I think part of it may be if you're twisted, if the anastomosis is too tight, of course, those, or if you have too much retained mucosa, obviously you're going to have some sort of retention, colitis or pouchitis. But I think a lot of this, as I said, may be due to other immunological problems. I said earlier, is I brought this up initially with people in St. Mark's to say that they should look at the association between extra GI manifestation and pouchitis, because I see that there's quite a direct correlation there.
Do you put
sorry to interrupt, but Dr. Abhinav has joined, so maybe we can.
So we will.
You wanted to show something. You show that.
Yeah. We will start that in 8:30 p.m. There are 7 minutes. Yes.
Yes. Please.
Do you, Dr. Chetan is not there. Dr. Chetan, would you put pelvic drain, and how many?
So generally we put only one drain, that is in the pelvis.
Okay. So now let me show you a very interesting case which just we finished at 6 p.m. today. Can you see my screen?
Not yet.
Okay. Oh, I'm not shared it. I'll share the screen, and please see and give your opinion also. Who can share? The host, allow me to share the screen, please.
Himanshi, please allow Dr. Das to share the screen.
Share the screen, please. This one. Okay. Share. Okay. Can you see this one? Can you see my screen?
Yes.
Yes, sir.
So this is a 42-year lady. In 2017, she was operated for ileal pouch anastomosis outside in somewhere else. And then she had a pouch anastomotic leak. And then the leak stopped. And then the ileostomy was closed. The ileostomy got opened inside. She was in ICU for a long time on inotrope. Somehow she survived, but the pouch outlet was completely gone, and she was an ileostomy. Every yearly once, she used to have pain abdomen and get admitted for 6 to 7 days, thinking that it was obstruction, antibiotic treatment, fluids, and she would become okay. This time, 7 days back, she came here. She had severe pain in the lower abdomen, below the umbilicus, and the pain was going down towards the pelvis and really unbearable. And she was managed outside with IV fluids, antibiotic was not responding. She came here day before yesterday night. She was flown to AIIMS. And then when we did when I examined, I thought I found tenderness in lower abdomen, and abdomen was distended. So I thought it was obstruction. I did a plain X-ray abdomen. The bowel was absolutely fine, and the ileostomy was moving perfectly with normal bowel sounds. So we treated for 2 days or so. The pain was going on increasing. Then I did a CT scan today morning. The CT scan interestingly showed that the pouch is hugely distended with a turbid fluid. So we thought possibly this is the problem that is causing. And then we tried the pouchoscopy and then to drain this one. And the outlet of the pouch was completely scarred. We tried from above and it was also not going down into the pouch. So we decided for a percutaneous drainage under ultrasound guidance. We can see the turbid fluid and we aspirated, it was pus. And this was the distended pouch. And we put a percutaneous drain and nearly 1 liter of pus came out from it. Now, what had happened is, now there was a blockade here, completely sealed off, and this person, when she was there in the other hospital, the ileostomy was closed. The ileostomy closure side was this, and then the proximal ileostomy was done to cover that. Initially, there was trickling of the fecal matter inside, and then this got completely closed. Now this has become a closed loop. Now, this patient is very, very interested, and after me, she had gone to Cleveland. All this had to do a redo pouch in this patient. Now, what should be actually the treatment from now onwards?
Actually, I think this is not an uncommon scenario. The pouch I find in eyelid anal pouch is sometimes made too big. When it's very big and it's a female, it tends to happen. I'll tell you what happens. Because the pouch, initially we think the pouch should sit erect or upright. But often the pouch gets bigger and bigger because of eddy current within the pouch. And then the pouch, like the uterus, flops forward. So the pouch flops forward. What you have then is you get a functional obstruction between the pouch and the anal canal.
Yes.
You know, so there's a flat valve effect at the lower end of the pouch and at the junction of the anal canal. So that becomes, when they strain, the upper edge of the back wall actually goes down and flaps, so that becomes a closed valve. And over time, this part, because of the constant pushing and pushing, it becomes stenotic and becomes inflamed and stenotic. So what we have been advocating is, when we do a pouch, we don't make the pouch too big. So in the old days, we used to say 20 cm or more, but now we are getting more to like 15 cm pouches. And also to be careful that a pouch, you know, in a female especially, may be a good idea to put a couple of stitches to hold the pouch up rather than letting it flop forwards. Because if you look, your drawing and the lateral CT scan is not totally the same. You see that your drawing, the pouch is sitting straight, like we would think a J pouch should sit. But your CT scan, you see that the wide pelvis AP diameter, you see that the pouch is actually lying horizontal, and the anal pouch angle, you see that the anus is actually going towards the back, whereas most anal canal in normal patients should go towards the front, and you see that the pouch is lying on top of the anal canal and closing it off. You see that?
Yeah. See, yes, it is. Yes, it is. And what would you suggest, to take out the pouch in this setting, or will there be a chance of getting a redo pouch in this patient?
No, I think you should try not to redo the pouch. In this patient, why don't you try to put a a drain, like a catheter. Now that you have drained the pouch, put a catheter within the inner canal into the pouch to drain it. And if you have to go in to do this, you can see if you can mobilize the J pouch and try and pull the J pouch straight up and stitch the posterior part of the pouch to the sacral promontory, so that you hold it straight up rather than letting it flop downwards.
Okay, thank you very much. We'll try to do that. I'll give an update personally about this patient and ask for suggestions. Thank you, Dr. Chetan. Thank you, Dr. Chetan. Are you there?
Thank you very much.
Thank you very much. Thank you very much. We'll go over to the next topic. Dr. Abhinav is there with us now.
Yeah. Thank you, Dr. Das. At the outset, I would thank Dr. Kapoor.
Yeah, Dr. Abhinav, let me introduce you.
Yeah.
So you are an alumnus of SGPGI. You did your DM in gastroenterology there when we were there.
Yeah.
And you are presently a faculty and consultant in the CK Birla Hospital in Jaipur.
Yes.
Yes. So you would be speaking about the topic of association of colorectal of malignancy with ulcerative colitis, which is a very burning issue, and still we are undecided at certain points regarding the management. So we look forward to see your talk.
Thanks for kind introduction, Dr. Das. I'll share my slides. Hope they are visible.
They are visible.
Yeah. Okay. Yeah. So this is, as you already said, this is a very important topic and certain things are not yet decided. So first of all, let us understand whether this is the same disease we are talking about as sporadic colorectal cancer, or this is a different disease entity. So this is the difference between sporadic colorectal cancer and colorectal cancer in the setting of ulcerative colitis. In ulcerative colitis, mucinous and signet cell variety are found more often, and the pathogenesis is slightly different. Means in sporadic colorectal cancer, adenoma carcinoma sequence we all know with the loss of function of APC gene. While here in ulcerative colitis, chronic inflammation leads to dysplasia, and dysplasia leads to cancer. So the pathways and signaling pathways and mutations and timing of mutation, they are different. So probably this is a slightly different disease as compared to sporadic colorectal cancer. So I would start with a recent case I encountered last week only. The lady has been on irregular follow-up. So this lady had a left-sided ulcerative colitis diagnosed way back in 2005, almost 18 years from now, and received multiple courses of steroid initially. Then later on, she developed diabetes, so she refrained from the steroid, and she had relapsed. So she landed up with a stool frequency of 7 to 8 per day, no blood. But her last colonoscopy was done in 2015. So last 8 years almost, no colonoscopy or screening has been done, despite the disease being of duration of 18 years, 18 long years. And last colonoscopy, it was grade 3 ulcerative colitis. Incidentally, her grandmother also had chronic diarrhea, which was never investigated. We don't know what was the cause. So we advised her scopy, but she was very averse to scopy, so didn't go for it. And she was also irregular on treatment. Every time we basically used to advise colonoscopy, she never agreed. Even sigmoidoscopy, she would refrain from. And she has continuous disease activity in the form of 8 to 10 stool per day, though blood was not there. In between, she stopped treatment altogether and switched to Ayurvedic treatment. So patient was not very compliant. Now, last week only she landed up with intestinal obstruction, gross air fluid level, pain, vomiting, and all those symptoms of obstruction. So we evaluated, and she was found to have a thickening in ascending colon cecum area with intestinal obstruction, obviously, and with the heterogeneous kind of opacity in the terminal ileum, suggestive some vegetative material probably was there. This time she agreed for colonoscopy, and we found a stricture at ascending colon cecum junction, which was a passable stricture. The mucosa overlying is not typical of malignancy here because it is smooth glistening mucosa. The lining of stricture had a deep ulcer, and we carefully negotiated scope without any resistance. In cecum, there were moon crater-like of deep ulcers, which actually we usually see in CMV superinfection. And in terminal ileum, there was a phytobazole, which was impacting the terminal ileum and was the cause of obstruction, not the stricture per se. Now, sir, we sent the biopsy, and surprising biopsy came out as a well-differentiated adenocarcinoma, though endoscopic appearance didn't look like a malignancy. So this is to summarize. This lady has ulcerative colitis for last 18 years, which is left-sided to begin with, poorly controlled. She was on irregular treatment. In between stopped treatment. Follow-up was also irregular. She was averse to endoscopies. There was no surveillance colonoscopy despite 18 years of disease. She has had family history of chronic diarrhea in first-degree relative, that is mother, which was not investigated, and she develops colorectal cancer. Now, so this is a very old study, 2001, got published in Gut 2001. This is a meta-analysis. And what is the risk of malignancy in colorectal cancer? So this graph clearly illustrates that as duration increases, duration of disease, cumulative risk increases. 2%, 8%, 19%, 10 years, 20 years, and 30 years. So the risk is dependent on basically duration of the disease. Now, what are the risk factors for colorectal cancer and ulcerative colitis? So this elegant study, very old one, NEJM 1990, this study has approximately 30,000 patients from Swedish registry. And what they looked at was age at diagnosis and extent of involvement. And as we can see in the boxes and the arrow, the pancolitis is associated more with a colorectal cancer than proctitis and left-sided colitis. And as earlier the age, more is the risk of the colorectal cancer. So this study, the conclusion was risk of this meta-analysis conclusion was the risk of colorectal cancer is higher with young age at diagnosis and presence of pancolitis rather than left-sided colitis. Now, this study basically again look at cumulative incidence of CRC with duration of disease, and you can see the plot there on the right side that as time from the diagnosis increases, the frequency again goes up. So cumulative, the figures are different here because we are dealing with Australian population here, but again, this study is illustrated that longer the duration of disease, higher is the risk of the colorectal cancer. So colorectal cancer risk is dependent upon duration of the disease, very well illustrated here in a different basically population cohort. Now, this study basically looked at another risk factor, presence or absence of primary sclerosing cholangitis. So on the right side, there is Kaplan-Meier curve. The dark lines relates to those patients who have ulcerative colitis, but no PSC, and gray line down there is PSC with ulcerative colitis. So presence of PSC increases risk of colorectal cancer from 2.9 to 5.8%. So presence of PSC doubles the risk of colorectal cancer. So PSC is a risk factor. Now, gender differences, this is data from Hong Kong. There approximately 7.5 lakh subjects, from them this data was drawn. And risk of colorectal cancer again is dependent on gender differences. Females are protected, possibly because of estrogen. So CRC you see is less common in females. Now, this is another study, basically fairly large number of cohort and IBD with family history and without family history. So if there is a family history of colorectal cancer, IBD patient have higher risk of colorectal cancer, and this is to the tune of 8-fold risk. So family history of IBD, there are chances of CRC and UC patient 8-fold increase. Now, this is a very important concept recently published in the Gut 2019, cumulative inflammatory burden. So what is cumulative inflammatory burden? Means what over last couple of years, what has been the inflammatory burden? So they calculated inflammatory score at macroscopic examination and microscopic examination both, and then between the different intervals multiplied by time of interval. So you can see the bar diagrams 2004, 2006, 2008. So these are timings of surveillance, and the score is calculated with the formula given above, and total cumulative burden is calculated, and then they basically looked at whether the risk of colorectal cancer is associated with cumulative inflammatory burden. So this Kaplan-Meier plot, you can see as cumulative burden increases, risk of colon carcinoma goes up. Now they also this analysis also shows that this is not related to one-time severity or maximum severity in last colonoscopy, but this is persistent of inflammations. Persistence of inflammation will lead to colorectal cancer. So risk of development of colorectal cancer is strongly associated with cumulative inflammatory burden rather than this disease duration simply, or rather than simply duration of severity of inflammation in last colonoscopy. So this is like we don't have to see the snapshot. We have to see whole video, the complete duration of disease, how much inflammation has been there in the colon, and that is associated with risk of colorectal cancer. So coming back to the lady we just encountered, she has long-standing disease for 18 years, which is poorly controlled, means higher cumulative inflammatory burden. She has been irregular on treatment, no surveillance colonoscopy, and probably her mother might also have had ulcerative colitis, which was never diagnosed. So these are the risk factors. And so uh, all these parameters make her to fall in the high risk category for colorectal cancer, hence she developed cancer. Now coming to surveillance strategies, then obviously we know that surveillance is being done by colonoscopy. So what are the guidelines? So these are different guidelines from different societies and associations. The gist of these guidelines is that first screening colonoscopy, it has to be done at least first colonoscopy has to be done 8 to 10 years after the onset of symptoms. And further colonoscopy based on risk stratification. So patients are stratified in high risk, intermediate risk, and low risk category. In high risk, screening is recommended annually, intermediate every 2 to 3 years, and low risk every 5 years. So what is high risk? High risk basically are patients with IBD who have first degree relative who had early colorectal cancer. That means less than 50 years. That qualifies for high risk. Intermediate, first degree relative with CRC, but after 50 years of age. IBD with dysplasia, high risk. Extensive colitis with severe inflammation, high risk. And presence of primary sclerosing cholangitis is high risk. So these patients have to be screened annually. Other than more than 50-year family first degree relative with colorectal cancer, another criteria which has been outlined in ECO guideline is moderate active inflammation that puts patient into intermediate risk, and these patients would be screened every 2 to 3 years. Low risk are patient or those patients who either have left-sided colitis and with minimal inflammation or no inflammation, who well-controlled disease in remission and no dysplasia. So every 5 years these patients will be screened. So first colonoscopy and then the repeat colonoscopy intervals, very well outlined by these guidelines. The problem is adherence. And this elegant study, 2002, recent one only, elementary pharmacotherapeutics, they looked at adherence to endoscopic surveillance. Means we are advising them colonoscopy, how many of them are turning up? So fairly good number of patients, around 1,000 patients, 700 ulcerative colitis, and this is the non-compliance rate. Means either they didn't turn up for colonoscopy at all, or they delayed their screening colonoscopy. It was very well seen from this study that low risk group non-compliance rate was 13%, but in high risk group, almost 40% patients didn't turn up. Means higher the risk, more is the non-adherence to compliance. So this is important issue here. And what reasons they cited for non-compliance? One was transportation, non-availability of finances or non-arrangement of finances. Some patient, they felt that colonoscopy will be procedure with lot of discomfort, and sometimes bowel, they didn't want to do bowel preparation. So non-compliance is the issue. Now, how to do surveillance? So we have traditionally we have been doing routine colonoscopy, which is called white light colonoscopy. But now later on, various modalities have come up to improve the yield of dysplasia or colorectal cancer detection in colonoscopy, that is chromoendoscopy. Then newer technology, narrowband imaging from Olympus, Fusionon from FICE from Fusionon, and iScan for Pente. This is called optical chromoendoscopy. And newer modalities are coming up, not in very much use, but probably modalities of future: autofluorescence, confocal laser microendoscopy, endocytoscopy, and FUE. So we are doing white light endoscopy. This kind of lesion is found on the background of just little bit erythema mucosa. What to do? to biopsy or not to biopsy. So this is always the confusion. White light endoscopy miss rate is 2 to 6% of the colorectal cancer, which is not a small number. Now, somebody asked this question on Quora, okay, what is function of staining in light microscope? You can see on the left side, unstained tissue, we can't identify anything. And to study the tissue in detail, we need staining. Same way, if we put stains on this lesion, which was non-descript on white light endoscopy, the lesion stands out very, very well. So we can take targeted biopsy, and usually the stains are methylene blue or usual iodine, so these kind of stains. So what is the impact of staining? On left side, the finding which can be easily missed as an area focal erythema, we can see that we can see a line of demarcation after methylene blue, and this lesion is very well standing out. So the miss rate can be brought down. And this basically turned out to be high-grade insight with the colonic neoplasia, missing which might have very deleterious effect to the patient. Now we know that everybody has unique fingertip mark, and it has been incorporated in Aadhaar card also in India. So likewise, colon also have pit pattern, which is unique to the type of pathology. And with change in pathology, the pit pattern, they get modified, or they are different. So the Kudos classification classifies them into non-neoplastic pattern, neoplastic but non-invasive pattern, and invasive pattern. So on chromoendoscope, we can find out, and this is the meta-analysis. This is a very accurate diagnostic method by doing chromoendoscopy. By studying Kudos pit pattern, neoplastic lesions can be identified with a lot of accuracy. Now, this is a comparison between white light endoscopy and chromoendoscopy, and chromoendoscopy improves detection rate of dysplasia. But if you have high definition endoscope, then basically it was found that high definition endoscope basically is equal to chromoendoscopy. So improvement in endoscope can also improve detection rate. This study very well outlines that. Now, problem with chromoendoscopy is it's cumbersome, it requires special stents, and it requires a special spray catheter. So nowadays, the endoscope itself has an ability called NBI spray, where we can filter out the red spectrum, and we can use pure blue and green light to improve the visibility of vessel. And as we know that as tumor basically develops, it requires blood vessels to feed it, and morphology of blood vessel changes. So on a click of button, we can do optical chromoendoscopy using NBI endoscope. No stain is required, no special catheter is required. It saves time. Now on NBI, the lesion on left, which is very nondescript on white light endoscopy and which can be easily missed, stand out very well in NBI mode without any chromoendoscope, without need of any special stain. And people have extensively studied, most of the study are there from Japan, and they've studied very well that what are capillary pattern associated with neoplasia and what are capillary pattern which are associated with adenoma. And they've been classified into NICE classification, JNET classification, and it has been very well established fact that with these patterns we can identify adenoma and we can identify invasive cancer. Now, so this lesion of sigmoid colon 6 mm, which was almost inconspicuous on white light, is basically low-grade adenoma with low-grade dysplasia on NBI imaging. And we can also detect cancers. So these are the type of polyp, hyperplastic adenomatous malignant polyp can be very well categorized using NBI scope and using the various kind of classifications. Now, what is the yield of basically NBI? So this is a meta-analysis of 13 study. Accuracy of NBI in diagnosis deep submucosal and invasion is sensitivity 77% and specificity 98%. So very good modality, and this is very quick one also. Now, in ulcerative colitis, image-enhanced endoscopy yields better result than white light endoscopy. And if you high definition endoscope, that is even better. NBI saves your time, and these are the studies to substantiate this fact. Now, coming to tissue acquisition, there are two protocols. The age-old random biopsies, every 10 centimeter, total 33 biopsies are taken, and targeted biopsy when we biopsy only suspicious area. ECO consensus in 2017, it recommended chromoendoscopy with targeted biopsy. So it saves time. And multi-center randomized control trial comparing these two biopsy protocols, it suggested that if you do targeted biopsy, detection rates are similar. So no need of biopsy every 10 centimeter, no need to take 33 biopsy. If you use chromoendoscope, if you use NBI scope, if you detect the lesion and do targeted biopsy, yield later similar, and the targeted biopsy less time consuming. So nowadays, the NBI means high definition scope, NBI scope and targeted biopsy is the way to go. Now, this is coming a modality, not very well available. This is basically just to highlight that what might come up in future. These are endocytoscope, ultra high resolution endoscope with 250x zoom, or routine microscope with 400 zoom. Here zoom is 250x. So you can even see mitotic figure, you can see nucleus, you can see nucleus, and you can make a diagnosis there and then itself. So this is the thing which is coming up. So other than these modalities, ultra fancy things, the basic thing which are there are very important. Is bowel preparation has to be very good. If bowel preparation is not very good, then you won't be able to see anything, whatever modality you might use. And we have to spend proper time in examination. And there is data to substance this fact also that endoscopists whose withdrawal time was more than 6 minutes detected more polyp than those who finished endoscopy in less than 6 minutes. So spending time and good preparation are very important. Now, a word just to slide on, basically, chemo prevention can be prevented since we have seen that cumulative inflammatory burden, if it is high, then carcinoma chances are high. And inflammation, adenoma, carcinoma sequence, it is the pathogenesis of colorectal cancer in ulcerative colitis. So if we keep inflammation suppressed, so we will be obviating the risk of adenoma formation and carcinoma in ulcerative colitis. So 5-ASA has very strong inflammatory property through suppression of various inflammatory pathways. And in meta-analysis 13 study, 5-ASA proven to have strong protective effect against colorectal cancer. So 5-ASA should never be stopped. Now these are the studies which basically this table summarizes various the various agents used in ulcerative colitis and their protective effect. 5-ASA, thioprine, UDCA, and anti-TNF agent. So all of them, they have protective effect against colorectal cancer. Means if you keep inflammation suppressed, colorectal cancer will not be there. And in ECHO recommendation 2017, ASA is for lifelong chemo prevention, but the compliance is issue, so we have to ensure the compliance. Thiopurine's problem of continuing thiopurine for long term is non-melanoma skin cancer and other cancers. So they have not been recommended as per guidelines. But basically, if you are using them, if you are forced to use them, then you have to basically be watchful for development of other cancer. UDC has only been recommended only in primary sclerosing cholangitis associated IBD, but not for prevention of colorectal cancer in ulcerative colitis per se. And biologicals, again, concerned about adverse events are there. So 5-ASA recommended, other agents conditional. Now coming back to our patient, this lady has a left-sided ulcerative colitis. Then why the cancer occurred on the right side? So on this, again, I looked at literature. There is enough data. This is systematic analysis. And approximately a significant proportion of left-sided colitis eventually, here in this study, follow-up was 9 years. So after that, end of 9 years, they go on to develop pancolitis. They evolve into pancolitis. And more so if they are basically unresponsive to 5-ASA or if there are ongoing inflammation, then they may progress to pancolitis. So this patient, when she was not very compliant and she was not on follow-up and she never had repeat scopies done, that time probably she might have evolved into pancolitis from left-sided colitis, and hence colon cancer developed on right-sided case. So this is my last slide. Colorectal cancer in ulcerative colitis is different pathogenesis than sporadic CRC. We are dealing with slightly different disease. Risk factors are early age diagnosis, longer duration disease, presence of pancolitis, family history, and coexisting PSC. The cumulative inflammatory burden is a involving concept. I feel this is a very good concept. High cumulative inflammatory burden in case of colorectal cancer. So we don't have to look at snapshot. We have to look at whole reel, how much inflammatory burden has been there. The screening for colorectal cancer dysplasia should begin 8 to 10 years after the diagnosis. Interval 5 years in low risk, annually high risk, and 2 to 3 years in intermediate risk. Thorough examination with white light endoscopy to detect target area, targeted biopsy. If we have image enhanced endoscopy, then the yield rates even better. And we have to keep inflammation suppressed to prevent ERC. Lifelong ASA should be advised to these patients for chemotherapy. Thank you.
Abhinav, that was a wonderful presentation.
Thank you, sir.
And so extensively dealt with, wonderfully described almost all the evidence tossed upon, and very nice messages coming out of it. Now, actually, it was a learning experience for me also. I have if I say for the students who have just entered into the GI surgery fraternity, can you give them an algorithm approach to the patient of ulcerative colitis where we find malignancy? Means first thing, please answer me. Once we diagnose malignancy, should we stop the immunosuppression if it's on?
The question is which malignancy you are talking about. If you are talking about other malignancy like colorectal, like skin cancer or bladder cancer or lymphoma, then obviously immunosuppression has to go.
Well, colonic.
Second, if a colorectal cancer has developed, then obviously you're going ahead with colectomy, and after that the immunosuppression will not be required at all.
Okay. And colonic rectal malignancies without the setting of ulcerative colitis, we say they are different.
Yeah.
So is it same for ulcerative colitis, the colonic malignancy, the prognosis, the rectal malignancy, the treatment is different or same?
If it is run-of-the-mill adenocarcinoma, then obviously treatment is going to be the same. Only thing adds up here is ulcerative colitis. But if it is mucinous, if it is a signet cell variety, then obviously the tumor is going to behave differently and will tend to have more aggressive clinical course. So, but eventually the treatment would remain same. As you treat other cancers, it will also be the same colectomy or same resection you will have to do depending on the stage of the disease. And similar kind of follow-up you'll require.
Does CA holds good like any other colorectal cancer here?
I'm not sure because in Indian patients, CA is not that very well correlated. At least in our clinical practice, we don't see that it is, despite the colorectal cancer being there, CA tends to be normal here in Indian patients.
See, the prognosis, vis-a-vis the stage per se, stage, if we compare the prognosis of colorectal malignancy in ulcerative colitis versus colorectal malignancy per se, the prognosis is different.
The problem with ulcerative colitis is a long debilitating disease, and the patient is usually nutritionally depleted, and surgical outcomes would be not that good as sporadic colorectal cancer, where patient is otherwise healthy. So these patients are hypoalbuminic, nutritionally depleted. They have chronic inflammatory state. They are anemic, so they will require more optimization to get a better surgical result.
And the genetic parameters or genetic studies same in both the situations?
Genetic pathways are different of both of the entities. Here, in the sporadic, you have adenoma carcinoma sequence, you have APC gene mutation, P53 gene mutation comes very late in that case, while here P53 gene mutation comes early, APC is late. So pathogenesis genetic-wise, it's different here.
Regarding the treatment, as like seeing microsite RNA, microRNA instability and KRAS genes, are these do these hold good for colorectal malignancy in a setting of ulcerative colitis?
MSI, I'm not sure, but obviously the signaling pathway are different. KRAS gene mutation frequency are different, but MSI, I'm not sure.
Dr. Das, I may interrupt. We have a tradition to close exactly at 9, so we will have to kind of close. Before closing,
Yes.
I'll make an announcement. So students, if you send me a mail at vkkapoor.india@gmail.com and write UC in the subject of the mail, so I'll send you the chapter on restorative proctocolectomy from my operative surgery textbook. So with that, I would like to thank Dr. Das for chipping in at the last minute to moderate this session, to Dr. Francis Seow-Choen from Singapore, Dr. Chetan Kantharia, and Dr. Abhinav.
Thank you,
Thank
sir.
you. Thank you very much. Thank you. Thank you, everyone.
Thank you, sir. Thank you.
Bye. Bye.
Dr.